evening, good evening. This is Dr. Vivek Goyal, Faculty of Medicine, and I'm here to discuss nephrology with you. And today is the fourth day of our nephrology discussion, and I'm very happy, very happy to see some familiar names, because I've understood those people who are very active in chats and very active in asking me questions as well. So I've kind of understood how much inquisitive is who, and I hope you're all safe, doing very good. So am I. And so let me begin with our customary. How's the Josh? Very high, sir. How's the Josh? Sky high, sir. How's the Josh? Unbeatable, sir. That's the way. That's the way. Mahi way. So I shall, as usual, I shall like to begin today's class with a thought for the day, and the thought for the day from my side would be, a very famous quotation from a very famous Hindi movie. I don't know how many of you have seen it, but yeah, it says that अगर किसी चीज को तुम पूरे दिल से चाहो, so पूरी कायनात तुम्हें मिलाने की कोशिश में लग जाती है. So basically, if you want something wholeheartedly from the bottom of your heart, the entire universe conspires so that you can attain your goal. Is it clear? Yes, I know some people who don't know Hindi. I am absolutely translating it for your good also. Okay? So I really appreciate this, and I really believe in this, that if you really want something, from the bottom of your heart, everything else does not matter. And if you just are blindfolded to the rest of the distractions, and if you keep moving to your only goal with focus, with all the dil and all the cha that you have, trust me, the entire universe will conspire for it. Okay? And of course, let us remember my idol, though I am not a great swimmer, Michael Phelps. This being absolutely defies all the limits of humanity according to me. All the limits of humanity according to me. The most decorated sports person on earth ever, and he has single-handedly won more gold medals in a single Olympic than many countries have won together in all the Olympics cumulatively. And I think you all know the story that the experience, the incident that he went through when he broke the world record of when he broke the world record in the Beijing Olympics. And I think that in the butterfly swimming competition, in the butterfly swimming round, what happened was, right in the initial part, I had read his interview, right in the initial part of the race, his eye gear broke and water entered into it. So he was literally blinded, but still he could have opted to stop then and there and make an excuse कि अच्छा water entered, I could not see. But this guy, he didn't bother anything. He thought, so what if I don't see anything? Let me put more vigor into my hands, into my legs. And trust me, the moment he completed the race, he was absolutely blinded, and the moment he opened his eye gear and saw up on the screen, do you know what did he read? He read WR. WR stood for World Record. So in the greatest times of adversity, the greatest being inside you comes out. So are you ready? Are you ready to bring out the toughest in you? Yes, you are. Okay? So now, with this gusto, with this zest, as I always say, let us begin today's class, and let us begin today's class and we were discussing glomerular diseases. We have completed nephrotic syndrome in details. We have completed the classification of nephritic syndrome and glomerulonephritis also in details. And we had, if you just remember, we had divided the glomerulonephritis or nephritic syndromes into antibody mediated, immune complex mediated, and post-immune. Antibody mediated had Good-Pasteur syndrome, Good-Pasteur disease, and anti-GBM disease. Immune complex mediated was further divided into immune complex with low complement, immune complex with normal C3. And then you had the post-immune, which had the ANCA vasculitis. I hope you are absolutely clear. Okay. So now, now let us begin our class, and we shall begin today with discussing anti-GBM disease. We shall discuss anti-GBM disease. Anti-GBM disease. Is it clear? Now, before I get into the topic proper, let me give you some mathematical equations and clear your concepts. There are some concepts which are not clear with most of us. So I would like to clear that first. Okay? So any combination which involves lung failure plus kidney failure this is known as pulmonary renal syndrome. So any disease entity which produces simultaneously the failure of lungs and the kidneys is known as pulmonary renal syndrome. Now, if in the lungs the person develops diffuse alveolar hemorrhage, and in the kidney the patient develops rapidly progressive glomerulonephritis, it is known as Good-Pasteur syndrome. It is known as Good-Pasteur syndrome. Now, if a patient has diffuse alveolar hemorrhage plus RPGN plus anti-GBM antibody, then it is known as Good-Pasteur disease. I hope I'm absolutely clear to all of you. So there are three terminologies, and I want it to be clear with all of you. Please do not be confused among them. So basically anything that produces the failure of the lungs and the kidneys together is known as pulmonary renal syndrome. If that has a alveolar hemorrhage in the lungs and rapidly progressive glomerulonephritis in the kidneys, that is known as Good-Pasteur syndrome. So this is known as diffuse alveolar hemorrhage, and RPGN full form I think you already know. I hope I'm absolutely clear. So there are three terminologies. So all Good-Pasteur syndrome is not Good-Pasteur disease. So that Good-Pasteur syndrome which has an anti-GBM antibody is known as Good-Pasteur disease. Is it clear to all of you? Good. And if a patient only has RPGN plus, so here this is absent, plus anti-GBM antibody that is known as anti-GBM disease. So basically, what is the difference between good Pasteur disease and good Pasteur anti-GBM disease? The difference is only one, that good Pasteur disease has lung involvement also in the form of pulmonary hemorrhage, whereas anti-GBM disease does not have lung involvement. So basically, they are two ends of the spectrum of the same disease entity. Are you getting me? So basically, anti-GBM disease is kind of a subset of good Pasteur disease. Clear? Now, let me ask you a ratio proportion, because I am very fond of mathematics. You know, I really loved mathematics. So if I ask you mathematics question, let me see who can answer this for me. What anti-GBM disease is to good Pasteur disease? What anti-GBM disease is to good Pasteur disease? So if let me write it down for you. What anti-GBM is to good Pasteur disease, IgA nephropathy is to. Let me see who answers this. Let me see who answers this. Let me see who answers this. So basically, I am asking you a ratio proportion. What anti-GBM disease is to good Pasteur disease? Anti-IgA nephropathy is to? IgA nephropathy is to? सर बहुत ही आसान है. If anti-GBM antibody is directed against the kidney, that is known as anti-GBM disease. If anti-GBM antibody is directed against the kidney and the lungs, that is known as good Pasteur disease. If IgA gets deposited in the kidneys, that is known as IgA nephropathy. If IgA gets deposited in the kidney, in the heart, in the GI tract, in the skin, that is known as yes, absolutely correct, Henoch-Schönlein purpura or IgA vasculitis. Beautiful. Most of you are absolutely correct. So you know, this is how you understand the concept of it. Okay. Now tell me one thing. If continuing in the same region, what anti-GBM disease is to good Pasteur disease and what IgA nephropathy is to Henoch-Schönlein purpura, scleroderma is to. I know that you have already been taught in rheumatology. Let me see who answers this. You need not write this. This is just to clarify the concepts. Tell me what IgA nephropathy is to Henoch-Schönlein purpura, scleroderma is to. Sir, बहुत ही आसान है. When anti-GBM antibody against the lung, that is known as against the kidney, anti-GBM disease. When against the kidney and the lung, that is known as good Pasteur disease. When IgA deposited in the kidneys, that is known as IgA nephropathy. When IgA gets deposited in the kidney, in the heart, in the GI tract, in the skin, that is known as Henoch-Schönlein purpura. When, sir, there is only fibrosis and thickening of the skin, that is known as scleroderma. When there is fibrosis and thickening of the tissues, of the skin, of the internal viscera, of the blood vessels, that is known as systemic sclerosis. So basically, just like scleroderma is a subset of systemic sclerosis, IgA nephropathy is a subset of Henoch-Schönlein purpura. I hope I am absolutely clear to all of you. Is it clear? Good. Some concepts clear today? Yes? Superb. So with this backdrop, let us enter into anti-GBM disease and good Pasteur disease. So see how mathematically we have clarified such concepts. Okay? We have clarified certain concepts. Good. Very good. That's a good. Good to go? Good to go. Give me a thumbs up. Good to go? Good. That's the secret. Good. That's the way. Now, how does this patient present? Now, let me discuss the clinical presentation of anti-GBM or good Pasteur disease. So basically, the patient can either be of two age groups, one in his 20s or one in his 60s. The one in 20s will have an explosive presentation. Sir, what do you mean by explosive presentation? So he will present with hemoptysis plus shortness of breath and with hematuria. So a young person usually has a explosive presentation. He straight away lands in the ICU. So he presents with hemoptysis and hematuria. Whereas as an oldie who is in his 60s usually presents with asymptomatic renal injury. He usually presents with asymptomatic renal injury. Am I clear? He presents with asymptomatic renal injury, whereas a young person has an explosive presentation, hemoptysis with shortness of breath and with hematuria. Is it clear? Now, who do you think will have a better prognosis? Now, at the outset, it seems that because the oldie does not have that explosive a presentation, he will have a good prognosis. But this is false. Absolutely false. They have a good prognosis and they have a worse prognosis. Why, sir? Because of two reasons. Because A, at least due to explosive presentation, they come to notice and they are immediately admitted and they are managed. But these patients, they have an ongoing renal injury and by the time they present, it's already very late. DAH means diffuse alveolar hemorrhage. Is it clear? SOB means shortness of breath. These are standard medical, abbreviations. I think you know this. Clear? Next. What are the triggers? The triggers are number 1, smoking, infection. Smoking and infection are the very, very common triggers. Trust me, I have seen quite a few patients of anti-GBM disease now. And the young males that I see are more often than not they are smokers. So smokers beware. Okay. So if you are a young male and you are a smoker, you definitely have the risk of anti-GBM disease. And if you are a young female, and you are a smoker, then please God save you from SLE. Then I said this to a girl. Then she came to me, sir, at least I will not have ulcerative colitis, sir. I was like, okay, you can save your gut and you can burn your body. Is it clear? All right. Now, one thing I forgot to tell you, this bimodal presentation, a person who is in 20s is usually a male and a person who is in 60s can be of either gender. Could be of either gender. Clear? Is it clear? So this is how they present to you. And this is the trigger. Clear? Very good. Now, yeah. So basically, a good Pasteur disease or an anti-GBM disease, whichever organ will it involve, it will ultimately lead to bleeding in that organ. Yes or no? So if a patient has diffuse alveolar hemorrhage, he is likely to present with hemoptysis. And if a patient has RP gene in the kidneys, he is going to have hematuria. So you will only see blood and blood everywhere. So it's a very bloody scenario. It's a very bloody scenario. Is it clear? Now, these are the triggers and this is this. Now, how do you diagnose anti-GBM disease or good Pasteur disease? Now, if you do an ANA, it will inevitably be negative. If you do a complement level, it will obviously be normal because it is a non-immune complex mediated disease. It is not an immune complex mediated disease. Is it correct? Yes or no? Absolutely correct. Good. Now, then how to diagnose this? To diagnose this, you need an antibody. Now the name is anti-GBM disease. So there is definitely something in the GBM against which the body is becoming anti. Yes or no? कुछ तो है GBM के अंदर that the body is not liking and the body is producing an antibody towards it. So that brings me to the question. What is the good Pasteur antigen? The good Pasteur antigen is NC1 domain of alpha 3 chain of collagen 4. Initially, if only you knew this, life was enough. But that was not the complete answer. So, if you answer alpha 3 chain of collagen 4, I will be happy but not happiest. But if you answer the complete form, that is NC1 domain of alpha 3 chain of collagen 4, please repeat with me. This is the complete answer. Is it clear? So this domain of the collagen 4 is the inciting factor, and who incites it? Be it an infection or be it smoking, and the body produces an antibody against this. So how do you diagnose good Pasteur disease or anti-GBM disease? You have to show the diagnostic antibody is IgG antibody against, please repeat with me, NC1 domain of alpha 3 chain of collagen 4. I told you yesterday GBM is composed of collagen 4 and there are 3 chains of collagen 4, alpha 3, alpha 4, alpha 5. This is that alpha 3 chain. Clear? Absolutely clear? Super. Good. Okay. Now let me give you an extra edge. You know that good Pasteur disease is not an ANCA positive vasculitis. It is not an ANCA positive vasculitis, but still, because whenever you get a pulmonary renal syndrome in the form of an RPGN or that is basically a good Pasteur syndrome, you always would like to exclude an ANCA vasculitis. So if you get an ANCA done, what do you expect? You expect ANCA to be negative, but to your surprise, P-ANCA can be positive in approximately 10% cases. It can be positive in 10% cases. The perinuclear ANCA, which is the diagnostic antibody of microscopic polyangiitis and eosinophilic granulomatosis polyangiitis, it can be positive in 10% cases. Sir, so what? Positive hai to hai? No, it has a significance. If this is positive, it is associated with good response to treatment. And if when I write this, I am reminded of an antibody which I taught you yesterday, which when was present was associated with bad response to treatment. Can you recall? On the right side of the table? Yes, you are correct. It was the anti-PLA2R antibody which was present in membranous glomerulopathy, which conferred a bad response to treatment. And here P-ANCA is a bin bulaya mehman, unwanted guest, in this setting, but still, if an anti-GBM antibody disease patient has a p-ANCA positivity, he will have a good response to treatment. So now we have absolutely understood this. Good. Good. This is the diagnostic antibody. Very good. So we will keep revising it as also. But now you said, sir, मुझे तो gold चाहिए, I want gold. So obviously you will get the biopsy done, and in the biopsy what you will get? You will get linear IgG deposits which will be ribbon-like. There will be linear IgG deposits which will be ribbon-like along the GBM, because it is the anti-GBM antibody disease, right? So the antibody will go and attack the GBM, and they will be deposited in a ribbon-like fashion linearly, and you will get this pattern. But I am not teaching you anti-GBM alag se or good pass-through alag se, because they are the same thing. So if you only have the kidney involvement, that will be anti-GBM, rest is absolutely the same. And if you only have lung and kidney involvement both, that is good pass-through disease. So the pathogenesis is the same, the clinical feature is just 1 and 2 separate, and treatment is the same, everything is the same. So I am teaching you together only. Last but not the least, sir, how will I treat this disease? How will I treat the good pass-through disease or anti-GBM disease? Sir, first of all, I will have to remove the antibody from the blood which is circulating, sir, and creating havoc in my body, which is the anti-GBM antibody, which is the basically IgG antibody. It is the IgG antibody against the NC1 domain of the alpha-3 chain of the collagen 4. Please revise with me again and again. So, to remove that antibody, I will get a plasmapheresis done. But sir, once I remove the antibody, will the body not produce more antibodies? Yes, it can. So to stop the antibody production, sir, factory को बंद करने के लिए, I will have to give immunosuppressants in the form of steroid plus cyclophosphamide. So this is the treatment. You have to give plasmapheresis plus steroid plus cyclophosphamide. Am I clear? And it goes without saying, anti-GBM and good pass-through disease have a bad prognosis. Prognosis is bad. Prognosis is bad. Is it clear? Absolutely clear. Superb. Now let me give you an applied question, because you are the next generation. #next. So you must be very good with applied medicine. So you are a pharmacology champs, I know. Please tell me one side effect of cyclophosphamide. Yes, you correctly guessed it. It is hemorrhagic cystitis. So basically cystitis means bladder ka inflammation. So it is basically hemorrhage in the bladder. So what will the patient come to you with? Patient will come to you with bladder mein hemorrhage hai. So ultimately it will come in the urine. So basically patient will come to you with hematuria. So basically you treated a good pass-through disease patient who had initially come to you with hematuria only. Yes or no? Yes. With cyclophosphamide, and again the patient had hematuria. So now after cyclophosphamide giving, patient had hematuria, you came to me and told me, sir, this is due to cyclophosphamide. I am telling, no beta, this is due to good pass-through disease. How will you prove me wrong and how will you prove yourself right? I am asking this, why? Because it actually happened with me when I was a first year medicine resident. Okay? So how will you prove it wrong? How will you prove me wrong and how will you prove yourself right? Very simple, sir. Concept of yesterday, sir, which I have to be applied. Sir, it's a cyclophosphamide induced bleeding. It is coming from the bladder, sir. Bladder se urethra, urethra se port, sir. No traffic. No traffic means that RBC, blood RBC, same to same. What is the fancy word for same to same? Isomorphic RBCs. Yes or no? Absolutely clear. So this will produce hematuria. Which will have no RBC cast, and that will be isomorphic, sir. But if it is coming from the good pass-through disease, that will be dysmorphic RBC, sir, and that will have RBC cast also. Yes or no? Absolutely correct. Good. I said this because this actually happened with me. I was fighting with my mentor. I was saying, no sir, this is due to cyclophosphamide. And sir said, beta, nothing doing, just get a urine RM done and get a good microscopy done. दूध का दूध और पानी का पानी हो जाएगा. And you know what happened? I was wrong. So this is a human trait. When you know less, you are very arrogant. No sir, I am right. You fight. And as you ascend up the ladder of knowledge, as you know more and more, you actually realize how much you don't know. So basically, the moral that I have learnt is, when you know more, you actually know how much you don't know. And when you know less, you think you know everything. Is it clear? So the most knowledgeable people on earth are the most humblest people on earth. Is it clear? Superb. Superb. So, good. This is how you see and you investigate and you treat the good Pasteur disease. Now, because I have raised this topic of pulmonary renal syndrome, let me just, because I always teach this and thankfully all my students could answer the question which just appeared this last AIMS paper. So I told you pulmonary syndrome is anything which has failure of both the organs. I told you this. So both organ failure. Yes, absolutely correct. So pulmonary syndrome can be caused by autoimmune disease. It can be caused by infections. It can be caused by drugs. And it can be caused by some miscellaneous entities. Yes or no? Yes or no? Good. Yes, you are right. Surgeons are full of swag and medicine people, though they have mugged up all the medicine books, still they are humble. Okay. So, can you tell me the autoimmune disease that have pulmonary renal syndrome? Yes, you do know. Sir, abhi padhaya. You can have good Pasteur disease. Yes. Number 2, sir must have taught you in rheumatology, there is a disease known as SLE. Yes, there can be vasculitis like granulomatosis polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis polyangiitis. There can be infections like Legionella. Number 1, Leptospira. Number 3, hantavirus, and so on. Is it clear? Is it clear? The drugs that can cause this are propyl thiouracil. Propyl thiouracil. It can be caused by D-penicillamine, and of course miscellaneous cause, which is actually very common than all of these together, is fluid overload. So fluid overload can cause pulmonary edema, can cause lung failure, and it can shut down the kidneys also. It can shut down the kidneys also. Yes or no? So these also can have pulmonary renal syndrome. So all these are causes of pulmonary renal syndrome. GPA means granulomatosis polyangiitis. Propyl thiouracil is this is it clear? MPA means microscopic polyangiitis. EGPA means Church-Strauss syndrome, which is the new name of, and the new name is eosinophilic granulomatosis polyangiitis. So all these are causes of pulmonary renal syndrome. Pulmonary renal syndrome. I hope I'm absolutely clear to all of you. So we have completed the antibody-mediated glomerulonephritis, which is the good pass-through disease, and the anti-GBM disease in details. And just to revise, the antigen is NC1 domain of alpha-3 chain of collagen 4. The antibody is IgG. PN ka 10% good prognosis. Treatment is this. And you know 20s, 60s, 20s male, 60s male or female, 20 में explosive but bad, but good prognosis. इसमें silent but bad prognosis. Treatment is Plex, steroid and cyclophosphamide. That's the way. Super. Now, so if you see your table, we have already completed antibody mediated, immune complex mediated. In immune complex mediated, cryoglobulinemia already taught to you by in your rheumatology class. SAB will be taught to you in your cardiology class. I have taught you Henoch Schwann purpura taught to you in rheumatology. I have taught you IgA nephropathy and I have taught you PSGN. So what remains is lupus nephritis. What remains is lupus nephritis, and I have already had a talk with Srinath sir, and I know he didn't teach this, and I know that one person has already taught it. I did talk to him in the morning. That is your favorite pathology teacher, Dr. Ranjit. I know he has taught you this, but still I know if I don't teach you, you will get hyper. So I will just try to revise very quickly. So please tell me very quickly, antibody associated with increased risk of lupus nephritis. Quickly. Antibody associated with decreased risk of lupus nephritis. Okay, it's fine, we'll see that. So it's fine, don't worry. Which antibody in lupus is associated with increased risk of lupus nephritis? You are correct. It is anti-dsDNA. Anti-double-stranded DNA is associated with increased risk of lupus nephritis. And which antibody decreases the risk of lupus nephritis is anti-Rho, and उसका छोटा भाई anti-La. Rho is also known as SSA and La is also known as SSB. You are correct. They are also the antibodies of Sjogren syndrome or Sicca syndrome. Sjogren syndrome or Sicca syndrome. Is it clear? You know Rho, anti-Rho antibody has a lot of MCQs. Number 1, associated with Sjogren syndrome. Number 2, decreases risk of lupus nephritis. And number 3, it is associated with congenital lupus nephritis. Is it clear? Very good. So these are very, very important. Now, what are the, very quickly I will discuss the ISN RPS classification of lupus nephritis. How has the International Society of Nephrology and Renal Pathological Society has classified lupus nephritis? That is basically a pathological classification, which is number 1, minimal mesangial. Number 2, mesangial proliferative. Number 3, focal proliferative. Number 4, diffuse proliferative. Number 5, membranous. And number 6, end stage sclerotic. So these are the 6 type of this is the pathological types of lupus nephritis. Am I clear? Very good. Now Why is it important to me as a clinical nephrologist? Why is it important to me as a clinical nephrologist? It is important to me because I have to know that A, how will they present to me? And B, how will I treat them separately? So मेरे लिए what is important is, number one, how will each of them present to me? And how will I treat each of them? Yes or no? I must know this as a nephrologist or as a rheumatologist. Is it clear? So I must know what to expect in which type of glomerular pathology in the different types of lupus nephritis. Now, in the first two classes of lupus nephritis, they are very, very good because they have normal kidney function. They are practically silent and inert. They do not produce any nephrological symptoms, and they have best prognosis. So they might be absolutely clinically silent. So basically, if an SLE patient might be silent, she does not have any hypertension or raised creatinine or proteinuria in the urine, and still if you insert a needle into her kidneys and to do a biopsy, you might get a minimal mesangial glomerulonephritis. So they have absolutely normal kidney function, they have best prognosis, they are clinically silent. Is it clear? So one who is silent, would you want to treat it? Would you still want to irritate the immune system, give a lot of things? So they do not require any treatment as such. You will just treat the rest of the SLE manifestations. The treatment is only blood pressure control. The treatment is no treatment, only blood pressure control. You will only do blood pressure control. Is it clear? Now, as we come below, coming to class 3 and class 4 lupus nephritis. Coming to class 3 and class 4 lupus nephritis, which are the proliferative forms, focal proliferative and diffuse proliferative. I hope you know what you mean by focal and diffuse. Focal means less than 50% of the glomeruli are involved, and diffuse means more than 50% of the glomeruli involved. I hope it is clear. Absolutely clear. Very good. So when you have the proliferative forms, they are the most dangerous because they will be associated with the very, very severe and bad form of presentation. And what is that? They will have high blood pressure, high creatinine, they will have hematuria, proteinuria, and active and casts in urine. So they are the ones who are the very notorious. So they will have the active sediment in the urine. You know, we often use the word active sediment and bland sediment. I told you we use when we examine the urine, we centrifuge it. So in the centrifuge sample, if you do not get any sediment, kuch hai nahi. That means bland, meaning sada, simple, nothing. But if you get a lot of RBCs, casts, pus cells, proteins, if you get in the chemical examination, that means it has active sediment. Is it clear? So in the proliferative glomerulonephritis, you will get all the active sediment and they will have a nephritic presentation. You are correct. It's a nephritic presentation. Clear? Absolutely clear. Very good. So they have a high blood pressure, high creatinine and this is basically a nephritic. This is basically a nephritic presentation. Clear? Hematuria, hypertension, edema, proteinuria. Very good. Now, if you come below, if I talk about membranous, I hope you remember what I taught you in membranous. Membranous is a type of nephrotic syndrome, and membranous glomerulonephritis will present to you as nephrotic range proteinuria and other manifestations of nephrotic syndrome, that is hypoalbuminemia, lipiduria, hypercholesterolemia. Is it clear? Absolutely clear. And end-stage renal disease means there is nothing left, kidney is shrunken and there is widespread uremia. The creatinine is very high and the GFR is less than 15 ml per minute. So this is how lupus nephritis presents to you, and each class has a separate presentation. Now, if we are out to treating lupus nephritis, you know that the most dangerous is class 3 and class 4 because they are the proliferative forms and they are very, very dangerous. So you need all your armaments to treat them. You basically require all your armaments and you will give all your Brahmastra to treat them. That is why to treat class 3 and class 4 lupus nephritis, you will give them injection methylprednisolone plus IV cyclophosphamide which you will give monthly into 6 doses. So you will give methylprednisolone injection plus monthly cyclophosphamide injections, and once you attain remission, you will shift the patient to oral steroid plus immunosuppressant, that is preferably mycophenolate mofetil or cyclophosphamide. That is again oral. So this is how you treat class 1 and 2 and 3 and 4. So this is basically the treatment of lupus nephritis. So class 1 and 2 has to be treated by nothing, just we have to do a BP control, no active immunosuppressant treatment. Class 3 and 4 have to be actively treated with methylprednisolone and cyclophosphamide. Cyclophosphamide will have to be given monthly injections for 6 doses, and once we attain remission after 6 months, you have to start oral steroid with an oral immunosuppressant, that if the patient is affordable enough, you will give him mycophenolate mofetil, but since India is a poor country, we usually give oral azathioprin. You will give the patient oral azathioprin. Just a typo. Oral azathioprin. So if the patient is affordable enough, sir MMF देंगे. If the patient can't afford, गरीब patient है, sir azathioprin दो. One tablet is 2.5 rupees. MMF is expensive. Is it clear? Is it clear? Very good. What about membranous? Or class 5? Class 5 lupus nephritis. Class 5 lupus nephritis is not to be treated so aggressively. You will give the patient oral MMF or azathioprin plus steroid for 6 months. Is it clear? So you will give only oral MMF or azathioprin plus steroid for 6 months. And last but not the least, how will you treat end-stage sclerotic, sir? When the kidney is already gone, it is shrunken, it does not respond, there is no inflammation in the kidney to treat it. Why do you want to kill the patient by giving immunosuppressants when there is only one treatment of any end-stage renal disease, and that is renal replacement therapy? So sir, if the patient can afford and the patient has a donor, obviously the best form is transplant. If the patient cannot do that, then the patient will have to be undergone dialysis. So two forms of renal replacement therapy, which is common for any damn disease. So this is the table. So in one table, I have given you the entire lupus nephritis, right from its clinical features to its management and the entire concept. So the first two classes, mind you, it is not stage, it is class. Okay, my teacher was very particular about class and stage. Is it clear? Good. You know NY, how do you classify dyspnea due to cardiac origin? That is NYHA. And how do you classify dyspnea due to pulmonary origin? That is MMRC. What is what? NYHA is class, MMRC is grade. So never call NYHA to be grade and this to be class. That is class, this is grade. So and this IS and RPS is not stage, it is class. So we have class 4, class 5, class 1, class 2. Is it clear? This is how you treat lupus nephritis, different stages differently. I hope I'm absolutely clear. I hope I am absolutely clear. And of course, you know by your pathology class already that which is the most common class of lupus nephritis is the most common class of lupus nephritis is class 4, which is the diffuse proliferative glomerulonephritis. Diffuse proliferative glomerulonephritis. I hope I am absolutely clear. Clear? Now let me ask you, and nothing, it's just a terminology. No difference between class and stage, just a terminology. Okay. Is it clear? Yes, uremia means increase in BUN and creatinine. Let me ask you an implied question. Let me see who answers this. If a patient of lupus nephritis develops thrombotic complication. So tell me, a lupus nephritis presentation has thrombotic complications. Which class of lupus nephritis is he likely to be? Which class of lupus nephritis is likely to be? Yesterday I told you one mathematics equation. I told you nephrotic syndrome plus thrombosis is equal to membranous. So here also thrombosis is equal to membranous. And which class is membranous? It is class 5. So just see, I gave you old wine in a new bottle and most of you were absolutely deep down thinking, ye sir ne kya pooch liya? So you have to be more implied and you have to use your temporal lobe more often. Is it clear? And you have to convert them into spinal reflexes. My teacher always used to say that in your Viva exam, you answer nothing from the cortex. Everything has to be a spinal reflex. If you're thinking in a Viva, medicine Viva exam, you'll think and answer from the cortex, please, the train will be gone. It has to be spinal reflexes, just from year to year. Clear? Good. Last but not the least, though it has been taught to you probably, in the urine examination, in the urine of lupus nephritis patient, what will you get? In the urine of lupus nephritis patient, you will get all types of cell and cast. You will get all types of cell and cast, and that is why the pathologist, when looks at the urine sample under a microscope, he feels as if he is looking at the sky through a telescope and he is seeing a variety of stars and everything whatnot. That is why it is known as telescopic urine. That is known as telescopic urine. Is it clear? So urine in lupus nephritis patient is known as telescopic urine because it has all types of cell and cast. And if you ever do a immunofluorescence on renal biopsy of a lupus nephritis patient, if you do a immunofluorescence on renal biopsy of a lupus nephritis patient, So I'm reminded of my MBBS days. When I was in MBBS, when I used to stay in the hostel, and I used to go in my mess to eat. So my mess had a very unique thing. They used to have a monthly feast day. Okay, so on that feast day, what used to happen? They used to serve the least bad food. I will not say good food. They used to serve least bad food. So they used to make good pakwan of every sort. And me being a vegetarian and me having studied in Bengal, so they usually used to equate vegetarianism with paneer. So for me, so basically they believe vegetarian is equal to paneer and paneer is equal to vegetarian. So basically I used to get only paneer in that grand feast day, and the others used to have a delight. Now, so that was a feast day. So on that feast day, grand feast day in the mess, what used to happen was all the students used to come and dine together in the mess. Otherwise, some would have a call for a dabba, or some would order from outside or cook or whatever. But on the feast day, everybody used to have and come and dine there. So if you would enter the mess on the feast day, you would say that it's a full house. It's a full house because everybody has come here to eat together. Clear? So similarly, if you look at the biopsy of a lupus nephritis patient under an immunofluorescent microscope, you will see that, oh my God, the inflammatory markers are having a feast here, because sir, यहाँ पे IgG है, यहाँ पे IgA है, यहाँ पे IgM है, यहाँ पे C1q है, यहाँ पे C3 है. So sir, you have all the antibodies and you have the complements of the alternate pathway and the classical pathway, everything is here, and that is why sir, they are having a grand feast. That is why this is known as full house effect. That is why this is known as full house effect. Because you know why? Their inflammatory markers are telling to each other, chalo, good, let's go to the kidney. This is the lupus nephritis patient. यहाँ तो बहुत सारा खाना है. Plenty of food here. Let's come and dine there. Because the inflammatory markers are having a gala time. They are having a feast. So let's go and eat there because everything is there. Is it clear? This is known as full house effect. So full house effect in the immunofluorescence and telescopic urine in the urine, and the classification and the treatment. Is it clear? Good. So we have completed lupus nephritis also. You have completed lupus nephritis also. Very good. So next which topic will we study? Let us now study the BAP of all topics, because for me, a nephrologist, I know the bread and butter is going to be one topic. If I do not know the management of, I am going to have a very bad time, and that is known as diabetic nephropathy. That is known as diabetic nephropathy. First and foremost, let me tell you some statistics. 40% of diabetes mellitus patients develop nephropathy. So in toto, all the diabetic patients included, 40% patients will develop nephropathy, including type 1, type 2, everything. Is it clear? Good. So I see that diabetic nephropathy has already been taught by Arvind sir in diabetes class. Yes? Yes or no? Has been taught. Okay, all right. So I can at least invest my time in teaching you something more fruitful, because I can teach you a lot more things then. Okay? Good. Very good. I am proud of you. I am proud of you. But just before completing this topic, I will just say it is the most common cause of CKD, and it is the most common cause of adult onset nephrotic syndrome. Good. Very good. Very good. Superb. See, if I will not teach this, I will definitely invest some time to teach you something more. So, don't think that every teacher should teach you everything. Clear? At least I will teach you definitely something which will be more beneficial to you. Superb. Chalo. So, diabetic nephropathy is absolutely clear. And Arvind sir was my teacher. So I definitely know he will be teaching you much better than I can ever intend to teach. Okay? Because I have always been taught one thing, that one's teacher can never be wrong, and he's always right, and he's always the best. Clear? I have always followed this principle, and trust me, those who regard their teachers, their gurus to be, they really are respectful towards them, they go really far in life. They go really far in life. So, thank you. So with that, we have completed the classification, and we have completed all the nephritic syndromes in details. Good. Yes, I was a Damsonian. Okay? Alright. So, see the result. If you work hard, if you succeed, you can immediately, a few years later, be on this side of your phone or your tablet, and you could be in my place, and you could be teaching. And I'm pretty sure that all of you will be teaching much better than I have ever done. Okay? So let us now study the next topic, that is membranoproliferative glomerulonephritis. Let me teach you membranoproliferative glomerulonephritis, which is also known as MPGN. Membranoproliferative glomerulonephritis, also known as, abbreviated as MPGN. And you of course know that membranoproliferative glomerulonephritis is also known as mesangial-proliferative glomerulonephritis. Absolutely correct. Clear? So membranoproliferative glomerulonephritis is also known as mesangial-proliferative glomerulonephritis, which is absolutely the most wrong statement I have ever taught you. So membranoproliferative is not mesangial-proliferative, because if you remember, mesangial-proliferative means proliferation of the mesangium only, and that was found in which nephropathy? IgA nephropathy. You are correct. So membranoproliferative is known as capillary glomerulonephritis or lobar glomerulonephritis. This is the correct name. Absolutely clear. Now it definitely is immune complex mediated so definitely there will be low complements. There will be low complements. Is it clear? And this is the most common glomerular lesion. This is the most common glomerular lesion in, these are MCQs. Number 1, Number 1, cryoglobulinemia, and number B, so it is the most common glomerular lesion in cryoglobulinemia and malignancies. This is an MCQ. This was asked in very examinations. Very important MCQ. Clear? So most common glomerular lesion in cryoglobulinemia and in malignancies. Now, let me tell you, MPGN, the disease MPGN has undergone a lot of change in the last few years, because a new disease has been coined out of MPGN, and MPGN is not the same what it used to be. Earlier, MPGN was classified into MPGN type 1, type 2, type 3, but that classification is now absolutely obsolete. So now we do not classify them as 1, 2, 3. So if you were an older student, I only might have taught you that way, class type 1, type 2, type 3, but I do not want to teach you in that same manner. So the causes are, it could be primary MPGN or secondary MPGN. Primary is idiopathic, which is actually uncommon, and secondary is due to causes. What are the causes of secondary MPGN? Number 1, 2 infections, that is hepatitis C and subacute bacterial endocarditis. 2 autoimmune diseases, that is SLE and cryoglobulinemia. And last but not the least, malignancies, which are lung, breast, ovary. See, most of you are still fighting upon diabetic nephropathy. What I am teaching, first enjoy that. This way, this approach is absolutely wrong, students. If you request, I can teach you that also later on. But do not behave this way. If you keep fighting over trivial things, keep doing over what I am not teaching, at least enjoy and read what I am teaching you. This is absolutely wrong. I am making so much of an effort to make you understand and explain you things, but if you behave this way with me, I will definitely not like it. Clear? So these are the causes of the causes of MPGN. And if you do this way, I will stop looking at the chat box only. If you behave with me this way. Beta samjho, I am here to teach you and I am taking all the extra effort to do so. But you also have to reciprocate and you have to at least understand me also. I want to give you as much information as I can. Clear? Subacute bacterial endocarditis. Now, these are the causes. So how does MPGN present to you? MPGN, it presents, the clinical features are, it presents to you with systemic symptoms. The patient can have fever. The patient can have fever, malaise, weight loss. The patient can have hematuria, proteinuria. The patient can also have RPGN type of presentation in approximately 25% cases. And this disease is so bad that it can progress to end-stage renal disease in approximately 50% cases in 10 years. So MPGN again is a very bad disease. It will have systemic features, hematuria or proteinuria, RPGN and ESRD. Now you must have been noticing that I have neither taught you MPGN in nephritic syndrome because the classification don't mention it, and neither did I teach you in nephrotic syndrome. So sir, ये ना nephritic syndrome है, ये ना nephrotic syndrome है. Sir, what is it then? What is it there? It is both, sir. It can have a nephritic nephrotic syndrome presentation. It can be anything, sir. It can have a nephrotonephritic presentation. Clear? It can present either ways. It can present either ways. Alright? And it has a very, very bad prognosis because it progresses to end-stage renal disease in approximately 50% patients in 10 years. How do you treat that? How do you treat this? The treatment is, if the patient has a secondary MPGN, you have to treat the cause. If the patient has primary MPGN, you will give the patient steroid plus immunosuppressants. Steroid plus immunosuppressants. Clear? This is how you treat MPGN. Clear? Absolutely clear. Now coming to the last point or last topic of glomerular disease, the last topic of glomerular disease, that is a novel topic, and I think most of you have not even heard it. Most of you have not even heard it. That is C3 glomerulopathy. C3 glomerulopathy. Clear? Now I will do one thing. I will first make you write this topic in toto and then I will explain you. So please write with me fast and please write with me fast. Yes, Sakti Bhushan Patnaik. I'm absolutely smiling. I told you, be a smile broadcaster. So thanks for reminding me. And yes, whatever said and done, forget that. It happens. You know, बड़े प्लेटफॉर्म पे छोटी बातें होती रहती है. So let's forget that. Let's start once again with a broad smile on our face and let's get back to C3 glomerulopathy. Alright. So what is C3 glomerulopathy? Sir, C3 glomerulopathy is a recent disease classification that has number 1 dominant deposits of C3 and number 2 that has dominant deposits of C3 and little or no deposits of immunoglobulin or classic complement pathway. Classic complement pathway. Clear? Is it clear? So basically C3 glomerulopathy is a recent disease classification that has dominant or sole deposits of C3 and little or no deposits of immunoglobulin or classic complement pathway. Now, what is the pathogenesis of C3 glomerulopathy? The pathogenesis of C3 glomerulopathy is excessive activation of alternate complement pathway. So why will the alternate complement pathway get excessively activated? Who is the guardian of alternate complement pathway? Who is the guardian? Jo, if present, it tells all the kids of alternate pathway, sit down. No, you will not dance. Keep shut. Who is the teacher in the classroom of alternate complement pathway? The teacher is, or the regulator of alternate pathway is complement factor H. So if complement factor H is deficient, you know, if the teacher is not in the classroom, the bache will start dancing. Yes or no? So complement factor H deficiency, which is the regulator of alternate complement pathway, if that is absent, you are bound to have excessive activation. Yes or no? Next, if it is associated with C3 nephritic factor, if the disease is associated with C3 nephritic factor, which is abbreviated as C3NEF. Now what is C3 nephritic factor? It is an antibody that stabilizes C3 convertase. And you know, C3 convertase is that thing which when breaks down C3, then the alternate pathway is activated. So if an antibody holds the hand of C3 convertase and tells him, beta, you go and keep breaking C3, what will happen? There will be persistent degradation of C3, and if C3 gets persistently broken down, ultimately what will happen? There will be activation of the alternate pathway. Ultimately, it will lead to a vicious cycle and it will keep activating the alternate pathway. Yes or no? Yes. So basically, the two reasons are complement factor H deficiency and C3 nephritic factor associated. Now, what are the two types of C3 glomerulopathy? What are the two types of C3 glomerulopathy? The two types are dense deposit disease and C3 glomerulonephritis. The two types of C3 glomerulopathy are dense deposit disease and C3 glomerulonephritis. Because I am fond of maths, this is DDD, this is DDD, and this was previously known as MPGN type 2. So Purana MPGN type 2 has now become dense deposit disease. And C3 glomerulonephritis, sir, what is this? C3 glomerulonephritis is C3 glomerulopathy minus dense deposit disease. It is C3 glomerulopathy minus dense deposit disease. Write down, I will explain you. Don't worry, I will explain you everything. You will not miss a single thing. Clear? Clear? So, how do they present to you? How do they present to you is a question that is lurking inside your brain. So, basically, what age? Dense deposit disease is a disease of children and young adults. Dense deposit disease is a disease of children and young adults, whereas C3GN is a disease of older adults. the main presentation of dense deposit disease is proteinuria. Plus minus hematuria. Whereas C3 glomerulonephritis का main presentation is hematuria plus minus proteinuria. Plus minus proteinuria. Now, if you do, because it is C3 mediated, नाम में C3 है, if you do a C3 level and a C4 level, you will get C3 low and C4 to be normal in both. Yes or no? Yes or no? Of course yes sir. Of course yes sir. Now, a very important MCQ point, what is the associated feature of both of them? It is associated with number 1, optic drusen, and number 2, partial lipodystrophy. Whereas this is not associated with anything. This is not associated with anything. Is it clear? Is it absolutely clear to all of you? Or any doubts you have? Biopsy. If you do a biopsy of each, as the name implies, you will get dense deposits on the GBM of only C3, whereas C3 glomerulonephritis can have a membranoproliferative type pattern, or mesangial-proliferative pattern. So this is the everything about C3 glomerulopathy. I hope I am absolutely clear to you. I know I am not till now, but I will make myself very clear to you very soon. Please do with the writing of this topic, and this is very, very important. This is very, very important. Please write down. This is very important for next AIMS and for the next NEET PG, because this has been newly introduced in the 20th edition of Harrison, and I feel this is definitely going to be asked in the next exam whenever it is going to be conducted. AIMS for sure, and for the central institutes like PGI, JIPMER also. Is it clear? Is it absolutely clear to all of you? Now, please look at me now and focus here. Focus here. First, you've written everything. Now look at me. What happened was there was a disease known as MPGN type 2 pehle. So C3, the complement C3, it filed a case in the court. And it went to the judge and said, Judge Saab, bahut nainsafi hai sir. There's a lot of injustice, sir. Judge said, why beta? What happened? He said, sir, I killed the patient and the credit is taken by MPGN, sir. Why is it so unfair, sir? Why is it life unfair? I do all the deed, but MPGN takes the credit. Sir, I also want my name to be present on the death certificate, sir. Why should MPG and all the fun? Have all the fun. Sir, please sir, you create another disease for me. Judge said, alright beta, I will do some upkar on you and let me give you another territory and let me give you a land and let me mark your land as C3 glomerulopathy. So C3 glomerulopathy means, pathy means disease, glomerulo means disease of the glomerulus, C3 means where C3 is the hero. So C3 glomerulopathy is that disease where there is only one and only one hero, that is a protagonist, that is a villain, that is a supporting actor, that is a comedian, and that is C3. So what is C3 glomerulopathy? There is only and only deposit of C3 and there is no deposit of immunoglobulin or classic complement pathway. So the hero and the only hero of C3 glomerulopathy is C3. And I have abbreviated C3 glomerulopathy as C3GP for practical purposes. C3GP. Clear? Now, why does C3 glomerulopathy occur, sir? Because, sir, you know C3 is a very important constituent of alternate pathway and there is excess activation of alternate pathway. Sir, why does the alternate pathway get activated? It gets activated, sir, because the guardian was missing, the teacher was absent, so the complement factor started dancing. Or, sir, there was an antibody जिसने हाथ पकड़ लिया C3 nephritic factor का, and C3 nephritic factor is that C3 nephritic factor is that antibody जिसने हाथ पकड़ लिया C3 convertase का, and you know C3 convertase is that thing that breaks down C3. So the more C3 broken and the more alternate pathway activated and the vicious cycle continues. So basically both of them or either of them would lead to excessive activation of alternate pathway and lead to C3 glomerulopathy. Now, very importantly, what happened was, what we did, most of the C3 glomerulopathy were put into the disease entity dense deposit disease. Now please understand, dense deposit disease कोई patient का नाम नहीं है. It is not the name of a patient. It is a pattern on immunofluorescence. It is an immunofluorescence pattern name. Is it clear to all of you? Say ST elevation. ST elevation is the name of a disease? No sir, it's an ECG pattern. So it can be present in AMI also, it can be present in early repolarization variant also, it can be present in hyperkalemia also, it can be present in acute pericarditis also, it can be present in many things. Similarly, dense deposit disease, dense deposit on the GBM is a pattern of immunofluorescence. But C3 glomerulopathy most commonly presents with dense deposit disease as dense deposit pattern. Are you getting me? Absolutely getting me. Now, there was a subset of C3 glomerulopathy. ऐसे कुछ disease है where the hero is C3 but the pattern is not DDD. So DDD is the most common pattern of C3 glomerulopathy. Whenever C3 will get deposited, it will deposit it in a dense deposit fashion. But it might so happen that the disease is C3, hero is C3, but it did not do a DDD pattern. So what did we do? We did something, we created a dustbin and we kept all those patterns where the pattern of on immunofluorescence was not DDD but the hero was C3, and that the dustbin is known as C3 glomerulonephritis. And just see C3G and what have I written? It is equal to C3 glomerulopathy minus DDD, whatever is left over. I hope I am clear to all of you. I should be. And now things are very easy. I told you DDD was previously included in MPG and type 2, and DDD is a disease of young people. This is of older adults. The main presentation of DDD is proteinuria. Main presentation of this is hematuria. Because it involves only alternate pathway, so of course C3 will be low, C4 will be normal. And DDD has two important associations which are MCQ points. Very, very important. Very important. What are those? Sir, optic drusen. Optic drusen means lipoprotein deposits in retina. So optic drusen means lipoproteinaceous deposits in the retina, and lipodystrophy means what? Partially. You will see a patient where he's partially lost the fat in one part of the face, breast area and this area. So they have a partial lipodystrophy. So both of them are absolutely associated with DDD. And of course, if you do an immunofluorescence or a biopsy, you will get here dense deposit of on the GBM of C3, and here you will get a membranoproliferative or a mesangial-proliferative pattern. I hope I am absolutely clear to all of you. This is a very difficult topic, and if you read Harrison, you will not understand anything. I have tried to explain it to you. I have given you all the relevant information, probably a bit more also, so that you can answer any MCQ. Is it clear? Absolutely clear? Very good. Very good. Thank you. C3GP minus DDD beta, that is a dustbin. That is a dustbin where that condition, where the hero is C3 because it is C3 glomerulopathy, but the pattern is not DDD. So that pattern, that disease, where the hero is C3 but pattern is not DDD, is kept in C3GN, that is C3 glomerulonephritis. Now, come on, give me a smiley if you understood. That's it, super, bahut badhiya. Very good, very good. Now, I shall now move to the next topic, which is again very, very important, and I have already received a lot many questions from this topic and lot many doubts. Though I had not even started teaching you this topic, I had just given you the brief. While I was teaching the the basics of nephrology. And still most of you were very, very enthusiastic about it. Very, very enthusiastic about it. Is it clear? Now, so now I would request you all to have your, if you have drawn that, just for a second, revise the diagram of the PCT. I mean the physiology channels that I had given you, the photograph also on the club that I had shared with you. Please revise that very, very quickly, because that will be required now very, very soon. Is it clear? Now, the next topic is, I know, considered to be the most toughest topic by students, that is renal tubular acidosis. Now, renal tubular acidosis, by definition, it is, what do you mean by renal tubular acidosis? Achha, treatment, there is no treatment of C3 glomerulopathy. There is no treatment, only treatments are being tried, but nothing has worked till now. Clear? Clear? So as I told you, renal tubular acidosis, as if you can break the word, as I always do, renal means kidney, tubular means disease of the tubule, and acidosis means acidosis in the body. So basically, it is a disease of the tubule of the kidney leading to acidosis in the body. Yes or no? Yes or no? Don't worry, I will show you the photograph, you will understand then. Yes or no? Yes. So it is basically a disease. It is a disease due to impaired renal acid handling by the tubules. So renal tubular acidosis, or RTA, is a disease of the tubules, and tubules had been given a task by God. Tubules, the task was given was कि भैया आप लोग please handle acid properly. But tubules could not handle acid properly. They could not secrete the acid in time, or they could not reabsorb the base in time. And ultimately what happened was there was acid accumulation in the body, and that led to renal tubular acidosis. Clear? So that is a disease of impaired renal acid handling by the tubules. Now, let me give you some perspective. You know, there is a disease known as, there is something known as metabolic acidosis. And you know, metabolic acidosis on the basis of anion gap, it is classified into two. One is high anion gap metabolic acidosis and one is normal anion gap metabolic acidosis. This will be taught to you in your acid-base disorder class. So do not worry. This will be taught to you. So metabolic acidosis is basically of two types, hagma and nagma. Hagma is high anion gap and nagma is normal anion gap. Now hagma ke certain examples, one is chronic kidney disease, one is aspirin poisoning, one is lactic acidosis, etc. and lot many. That is not my topic. Now nagma ke there are two examples which we are very considerate about. Number one is renal tubular acidosis and number two is diarrhea. There can be more also, but I am right now concerned about these two. Why am I telling you this? This is so that you are getting the perspective clear that sir, you are currently teaching me RTA, which is a son of nagma, and nagma is a son of metabolic acidosis. So sir, basically इस परिवार के मुखिया, इस परिवार के grandfather, his family's head of the family was metabolic acidosis. It had two sons based on an ion gap. One was hagma, one was nagma. Nagma had a very important son which was renal tubular acidosis, and now we are going to study renal tubular acidosis. So nagma's father is, RTA's father is nagma, and nagma's father is metabolic acidosis, which we are going to study right now. Now, let me give you a very important concept of something which is known as urinary anion gap. You have studied about, this was serum anion gap. This was serum anion gap. Aspirin toxicity. Okay, my handwriting is getting a bit bad, so I would just like to tilt the screen a bit. Okay, so there is a concept known as urinary anion gap, abbreviated as UAG. Now urinary anion gap is calculated by urinary sodium plus urinary potassium minus urinary chloride. It is calculated as urinary sodium plus urinary potassium minus urinary chloride. This is the formula of urinary anion gap. Now, and also in the very first class I had told you something, that urinary acid is directly proportional to urinary H plus, which is directly proportional to urinary ammonium, which is directly proportional to urinary chloride. Yes or no? I told you this because the principal form of acid secretion by the kidney is in the form of ammonium ions. So you have understood that urinary acid secretion is directly proportional to urinary chloride. Yes or no? So what we did, we basically made urinary chloride as a surrogate marker. Surrogate marker of urinary acid excretion. Please understand this very, very carefully. This is a concept very few people understand, and because the reason is because they lack the knowledge of physiology. That is why I started from physiology only. Is it clear? So urinary anion gap is equal to urinary sodium plus potassium minus urinary chloride, and urinary chloride is nothing but a marker of urinary acid excretion. Why? I have given you the explanation. Clear? Absolutely clear? Now, I told you at the very onset of the disease, in renal tubular acidosis, there is decreased urinary acid excretion, because the definition was impaired renal acid handling. So I know RTA mein there is decreased urinary acid handling, so there is decreased urinary acid, so there is decreased urinary chloride. Yes or no? Yes or no? This has to be very, very clearly understood. I hope you don't have any doubt in this. So I know one thing again, one equation, that in renal tubular acidosis there is decreased urinary chloride. In short, absolutely clear? Absolutely clear? Now, if urinary anion gap is equal to urinary sodium plus urinary potassium minus urinary chloride, this is the basic formula, yes or no? This is the basic formula. Now, because this is the basic formula and because RTA mein this is low in RTA, this is low in RTA, so if something has to be, if basically something is A minus B, and if I decrease B, the total summation, the total equation shifts negatively or positively? Shifts negatively or positively? Tell me quickly. This is urinary anion gap, urinary sodium plus potassium minus urinary chloride, and urinary chloride is a marker of acid excretion. And because RTA mein acid is decreased, acid excretion is decreased, so urinary chloride is decreased. Now if urinary chloride is decreased, so this entire equation will become negative or positive? Quickly reply, negative or positive? It will definitely become, because urinary chloride is decreased in RTA, urinary anion gap is positive in RTA. Now this is the dictum, and please take it to your grave. This is a dictum, and this is a very, very important concept. So I hope nobody of you will have a confusion regarding understanding, sir, why is urinary anion gap positive? Urinary anion gap is positive in RTA. So I have given you two rules of RTA. Number one, RTA is a normal anion gap metabolic acidosis. So serum anion gap is always normal and urinary anion gap is always positive. Write down two rules. Number one, serum anion gap always normal, urinary anion gap always positive. Is it clear? Absolutely clear? Give me a smiley. Give me a love wala smiley. Give me a love wala smiley in your eyes. Quickly. Very good. Very good. That's the way. Super. Super. Now, if you have understood this, now things will become very, very easy for me. Things will become very, very easy for me. Good, that's the way. That's it. Superb, superb. I'm very, very happy. Now, let us now draw a table. Please take a fresh page. Please take a fresh page. Or let me take down a fresh page and divide your page into three columns. One is RTA type 1, RTA type 2 and RTA type 4. And we shall now draw a table and we shall beautifully understand what is what. We shall beautifully understand what is what, and whenever we don't understand, we shall write the reason also. We shall write the reason also. Now, please keep turning your pages back and keep looking where is the problem. Where is the problem? Now, the lesion in RTA1 If you can remember clearly the alpha intercalated cells of cortical collecting duct. Do you have the figure? Do you have the figure? Yes or no? Just remember, just try to recall, for your sake I am recalling this, for your sake. This was the alpha intercalated cells of the cortical collecting duct, and यहाँ से acid was being secreted, can you see this? यहाँ से acid is being secreted in the form of H plus and H plus K plus antipode, and if this does not work, you have RTA type 1. Very good. I told you this. In PCT, bicarbonate is reabsorbed through carbonic anhydrase 2. Bicarbonate is reabsorbed through carbonic anhydrase 2 because from here CO2 enters. Inside the PCT, and with carbonic anhydrase, it forms bicarbonate inside the cell. With carbonic anhydrase 2 forms HCO3, and this HCO3 ultimately gets absorbed. So if due to any reason my bicarbonate reabsorption is hampered, I will lose all the base, and if I lose all the base, I will develop acidosis. That was RTA type 2 or proximal RTA. I hope it is clear. And if I discuss the principal cell of cortical collecting duct, I told you if the aldosterone action is decreased or if there is resistance, there will be RTA type 4. So I have revised everything, and now my work becomes very, very easy. So now, what is the lesion in type 1? The lesion in type 1, where does the lesion lie? The lesion lies in alpha intercalated cell of cortical collecting duct. Now it is just amalgamation of all the information that we have. Please try to memorize the photograph of the channel. If you can do so, you will never forget it. RTA2, the defect lies in the proximal convoluted tubule, and RTA4, the defect lies in the principal cell of cortical collecting duct. Yes? What is the mechanism of the defect? In RTA1, there was, if you just remember, just recall it, there was a proton pump and H plus K plus antipode. H plus could not go outside. So mechanism was, there was decreased secretion of acid. Yes or no? Yes. If you remember RTA2, there was decreased reabsorption of bicarbonate, and RTA4 was decreased aldosterone secretion or decreased aldosterone action. Why decrease aldosterone action? Because of resistance. I hope you are all writing in a fresh page. So just see, one is a secretory defect, one is a reabsorptive defect. One is decreased secretory effect of acid, one is decreased reabsorption of base or bicarbonate. Very good. Clear? This is RTA type 4. Now please remember, what will be the serum anion gap and what will be the urinary anion gap? Can you please tell me quickly? I told you it's a dictum. Do not have to think so much. All RTAs are types of Nagma. So serum anion gap is normal in all the three. That's a routine thing. And urinary anion gap, please do not confuse yourself henceforth. I am giving you urinary anion gap is positive in all the three. It's a dictum. And it's a time tested question asked numerous number of times, but I know my students will never commit this mistake. My students will never commit this mistake. Please take it, it's a dictum. Now, come to serum potassium. Come to serum potassium. Clear? Clear? Now, in type 1, if you remember, the H plus was going outside, K plus was coming inside. Because this channel does not function, so you know, you will have hypokalemia here. Why? Because, why do you have hypokalemia? Because K plus could not enter. Please remember this. K plus could not enter through the alpha intercalated cells of cortical collecting duct. Now, coming to type 2, please understand this. What happens was, in type 2, there is bicarbonate loss. And bicarbonate loss leads to intravascular volume depletion. So water reabsorption also hampered. You have a water depleted state, and you know, in any water depleted state what happens? The RAS system gets activated. If the RAS system gets activated, you know, there is increased sodium and water reabsorption, and there is increased potassium loss. In short, type 2 RTA will be associated with increased potassium loss from the distal part of the nephron, and you will have a hypokalemic state. If you remember, the type 4 RTA principal cell, aldosterone was kicking out the potassium. Because aldosterone does not kick out the potassium, so what will happen? The potassium will build in the body, and there will be hyperkalemia. Because potassium didn't get excreted out. Because potassium did not get excreted out due to lack of action of aldosterone. Moral of the story, there is only one RTA where there is hyperkalemia, and this question has been asked it was asked in ancient times from Harappan civilization, and it is still being asked till now, that which is the hyperkalemic RTA. There is only one hyperkalemic RTA, that is type 4. So type 4 is also known as hyperkalemic RTA. Clear? Absolutely clear? Now, after serum potassium, let us come to, so we have understood that all have hypokalemia except type 4, which only has hyperkalemia. Is it clear to all of you? Very good. Now, if I ask you one more thing about urinary pH. Now please understand one thing, that I told you the principal site of acidification of urine is what? is alpha intercalated cells of cortical collecting duct. And which is the disease which is affected by, in which RTA is alpha intercalated cell affected? Type 1. So can I say that type 1 RTA will bear the maximum brunt of acidification in RTA? Because उसी के वो चैनल में डिफेक्ट है. इन टाइप 1 RTA ओनली दैट चैनल इज डिफेक्टेड विच इज द मोस्ट रिस्पॉन्सिबल फॉर एसिडिफिकेशन. यस और नो? यस. सो कैन आई से टाइप 1 RTA विल हैव द लीस्ट एसिडिक यूरिन? Yes or no? I cannot say basic. It will have the least acidic urine. So urinary pH here will be more than 5.5 and will be less than 5.5. Will be less than 5.5. So I have understood that there is only one RTA which will have the least acidic pH, and this is the next common question that is asked. That is the next common question that is asked. After urinary pH, if I ask you Fanconi syndrome, I told you what is Fanconi syndrome. Fanconi syndrome is basically the global dysfunction of proximal convoluted tubule, and you know that out of the three, which is the PCD defect? Type 2. So type 2 can have feature of Fanconi syndrome like phosphaturia, glycosuria, bicarbonate citraturia, amino acid urea, but rest of them will not have this. So next MCQ is which is associated with Fanconi's? Answer is type 2. Answer is type 2. Very good. Next concept. So basically we have understood that the important differences between type 1, 2 and 4, and 4 was still here only. No longer required type 4. Now we have the battle between type 1 and type 2. Okay? Next, come to the next topic, that is urinary calcium and urinary citrate So basically, urinary calcium. Now, let me tell you one thing that in any acidotic state, you know it is physiology. If you have read calcium reabsorption from the kidney, calcium reabsorption is hampered in any acidotic state. So, there is hypercalciuria in acidosis. So basically, if you want to take down the concept, you can write down that if you want to take down the reason, that is physiology. I'm again teaching you physiology because in chronic acidosis, it will lead to impaired calcium reabsorption and increased mobilization of calcium from bone, ultimately will lead to increase serum calcium and will lead to increase urinary calcium. So basically it's a concept that any chronic acidemia ultimately causes increased calcium secretion in the urine. Now, as I told you, because type 1 RTA is a more severe acidotic RTA. Why is it more severe? Because, you know, it has got a wound in the heart. In the heart of the kidney for acidification is alpha integrated cell. And the heart is damaged in type 1. So when the heart is damaged, the brunt will be lot more. So acidosis is much more. And the acidosis is much more, hypercalciuria is much more. Yes or no? Yes. Yes or no? Absolutely correct. Absolutely correct. Very good. Now after urinary calcium, come to urinary citrate. And I told you on the very first day, while drawing the PCT, make an arrow and get it reabsorbed in the PCT. You know urinary citrate is reabsorbed in which part of the kidney? The answer is PCT. Answer is PCT. So if PCT reabsorbs the citrate, now please tell me one thing, which among the two, 1, 2 and 4 is a disorder of PCT? PCT is disordered in type 2. If PCT is disordered in type 2, will citrate be reabsorbed? Yes or no? Not. If citrate is not reabsorbed, the urinary citrate will be high in type 2. They will be low or normal in type 1 and 4. Yes or no? Yes. So basically the moral of the story is you have increased calcium, increased citrate, increased calcium, low citrate. Did you understand this funda? Now please understand this one. Citrate, I perceive citrate, as a guardian of calcium. Whenever calcium particles accumulate, whenever calcium meets, they immediately make friends. And they make friends, they accumulate, then they form stones. But citrate is that guardian, that teacher who will tell, no, you go there, I will not let you come together. And if citrate does not let them come together, it will not let them accumulate. So basically, if there is only calcium, they will accumulate to form stone. If there is citrate, they will not form stone. Yes or no? So now, if I ask you the $1 million question for which so much concept was given, that is stone formation or nephrocalcinosis. You know that in type 1 there is high calcium, low citrate, there will be stone. In type 2, urine mein there is high calcium, high citrate, guardian is there will be no stone. Here also there is no stone. In short, which RTA is associated with stone formation is the next $1 million question. Answer is type 1. So which RTA forms stone? Answer is type 1 has stone. I hope I am absolutely clear to all of you. If I am, I think this topic has become very, very easy to all of you. Yes or no? Yes or no? Clear? Absolutely clear? Good. So I think we have already done 10 points. 10 points on RTA. 1, 2, 3, 4, 5, 6, 7, 8, 9 and 10. Please maintain the tabularity. Do not break the tabularity. Do not break the tabularity, okay? Keep writing it on a table only. Next, last 3 points. Last 3 points is causes. Causes. Type 1 RTA, the cause of type 1 RTA is that dance form which I wanted to learn since I was a child, but कमबख्त जिंदगी ने बहुत किया मुझ पे हंसी सितम and I could not learn it. And the causes of type 1 RTA are Sjogren's, amphotericin B, lithium, sickle cell disease and autoimmune disease like SLE. The cause of type 2 RTA are VAMP. You know, there are many bad politicians and ministers there. So if you have a VAMP MP, VAMP member of parliament, you are definitely going to suffer. And what will you suffer? You will suffer a type 2 RTA. And what do I mean by that? I mean Wilson's disease. I mean amyloidosis. I mean myeloma. I mean paroxysmal nocturnal hemoglobinuria. paroxysmal nocturnal hemoglobinuria, because beta type 4 में citrate is there in the urine. Type 4, leave that. Type 4 does not have stone. Type 4 is not required only, it was still there. Just remember what I am telling you. Okay? Okay? Is it clear? So, Wilson's, amyloid, myeloma, PNH, M for metabolic disease, and P for lead poisoning. And metabolic disease include everything like cystinosis, cystinuria, tyrosinemia, etc. etc. And last but not the least, the causes of type 4 are I don't know what you want to call it. They are dado, and by that I mean obstructive uropathy, diabetes mellitus, Addison's, and drugs. And of course the drugs are TASH. What do you mean by that? You mean T for trimethoprim, A for ACE inhibitor ARB, S for spironolactone, H for heparin. So these are the different causes. And sir, why have you made us write so many causes? Because let me tell you, question. So many questions have already been asked, and RTA is one of the favoritist topics of PGI Chandigarh. And if you want to appear for any foreign examinations like USMLE, please do not forget to read RTA. One of the most important topics. Clear? So this is about type 1, 2 and 4. The causes of RTA. Clear? Absolutely clear? PNH means paroxysmal nocturnal hemoglobinuria. Clear? I hope I am absolutely clear. Paroxysmal nocturnal hemoglobinuria. Clear? So these are the causes of different types of RTA. And now, last point, how do they present? How do they present to you? Drugs are TASH, T for trimethoprim, A for ACE inhibitor ARB, S for spironolactone, and H for heparin. H for heparin, spironolactone, ACE ARB, trimethoprim. Clear? How do each one of them manifest? Very, very important. Now, the basic manifestation of type 1 is they present with nephrocalcinosis, and hypokalemia. I will tell you a very interesting presentation I recently saw, and I am writing a case report also. Very uncommon presentation of the disease I saw. I mean, not so uncommon, but basically the way it presented with the complication of the primary disease, it was really very good. And we are writing a case report also. Type 2 presents with osteomalacia, and vitamin D deficiency. Type 4 basically presents with mild acidosis. And hyperkalemia. Clear? Absolutely clear. And last but not the least, how do you treat them? How will you treat type 1? You have to prevent the formation of stones, so you will give citrate therapy and you will give alkali therapy. That is sodium bicarbonate tablets. In type 2, also you will give alkali because everywhere there is acidosis, beyond doubt. Here you will give the patient vitamin D, and in type 4 you will give a potassium free diet. You will stop the offending drugs, and you can give the patient, if there is decreased aldosterone secretion, you can try fludrocortisone. You can try fludrocortisone. So basically what I was saying was, the thing I'm going to share, recently actually a patient was admitted under neurology department with flaccid quadriparesis, and they were thinking of a diagnosis of GB syndrome. Obviously, acute onset flaccid quadriparesis, they were thinking of it. So they got admitted, patient got admitted, they got a CSF done, CSF was normal. Now one thing they noticed was that the patient was having hypokalemia. Now because the patient was having hypokalemia, they tried to manage it with injection KCL, but the patient was having refractory recurrent hypokalemia. So then came the picture of a nephrologist. So I was called upon. I went and saw the patient, and I saw that I saw the RFT report. For the last 5 days, the potassium ranges between 2.7, 2.8, 2.9, 3.1, corrected 3.3, again 2.8. So the potassium was not getting corrected only. Suddenly I took a look at because the patient was in the ICU, I took a look at the ABG. ABG said pH of 7.21. So I thought this is acidosis. So I then got a urinary pH done, and urinary pH showed severe acidosis. So immediately I thought hypokalemia with acidosis, serum acidosis, and with urinary pH so low, I checked for the serum anion gap and the urinary anion gap, and they absolutely corroborated. Then I saw that the patient had a Ryle's tube through her nose. And when I asked to open her mouth was full of ulcers and very poor oral hygiene. And nobody had taken the effort to take detailed history from the poor lady. And I asked her in details. Then she said, "Sir, I have a lot of problems in chewing my food, sir. Sir, so much so, with one chapati I consume 3 glasses of water, sir." I said, "Why?" She was like, "Sir, because when I take the chapati, I cannot gulp it down. With one bite of chapati, I have to drink half glass of water because she is not forming saliva in her mouth." And then she said, "Sir, I always feel that, sir, there is a stone in my eyes. There is a grittiness in my eyes. But sir, when I check the mirror, there is no grittiness, sir." So basically, they was having a dry eyes, dry mouth, and she had a vaguely non-erosive joint pain also with hypokalemia, with a distal type of RTA. And then she also I got a history from her that, "Sir, twice I have been operated for renal stones. So what else is required? Female, dry eyes, dry mouth, nephrocalcinosis, hypokalemia, nagma, urinary anion gap." So this was basically a Sjogren syndrome presenting with a type 1 RTA, presenting with hypokalemic paralysis. So it was a wonderful case. It is a wonderful case. Till now the patient is with us, and I'm writing a case report. I will report it very soon. Is it clear to all of you? So I have given you these 13 points in RTA table, and trust me, if you can recall all the 13 and if you can write all the 13 on a piece of paper before the day of exam without seeing, trust me, nobody can stop you from answering any damn question. It is be it MD entrance, DM entrance, USMLE, MRCP. No question can be asked from RTA beyond this. I have included everything about RTA, and I hope now that thing which was very difficult to you should not be the same. Is it clear? Absolutely clear? Clear, all of you? Now I still have some time left and I will utilize it. Some people are already in a hurry. I think you all will not want to miss the next topic that I am going to teach, because I call it the gold mine of MCQ, and that is some hereditary glomerular disease, and I would like to start from Fabry's. I know you have been taught this in biochemistry, but probably the clinical correlation has not been taught because biochemistry people don't see patients. And luckily enough, I have only seen one patient of Fabry's in my life, and I am very lucky. Okay, I think myself to be very lucky. So please write down quickly. It is an X-linked recessive disorder. There is a deficiency of alpha galactosidase A. There is accumulation of globotriaosylceramide. Basically, this sphingolipid. So this sphingolipid gets accumulated inside the cells and it creates the disease. So Fabry's is an X-linked recessive, deficiency of alpha galactosidase A, accumulation of globotriaosylceramide. And what are the clinical features, sir? Sir, the clinical features are, it has corneal opacities. Number 1, corneal verticillata, which are basically vertical corneal opacities. Absolutely key word for MCQ. Absolutely key word for MCQ. Number 1, after eyes, come to skin. MCQ point, angiokeratoma. It is an angiokeratoma. Number 3, come to heart. You have conduction disturbances. Number 4, come to nervous system. You have autonomic neuropathy. Autonomic neuropathy. And last but not the least, come to kidney. That is why I am here. Kidney mein what will you get? You will get number 1, concentration defect, which is the earliest renal manifestation of Fabry's. AIMS MCQ. Old AIMS question. Earliest renal manifestation of Fabry's, concentration defect. Number 2, you can get proteinuria. You can get sometimes microscopic hematuria. You can also get microscopic hematuria. Is it clear? And now, if you do the biopsy of this disease, what are you likely to get? You are likely to get that which I have made you write in the miscellaneous cause of a nephrotic disorder. If you remember, do you remember? There are also urinary fat oval bodies, because there is lipiduria, and that can lead to a Maltese cross, as I taught you yesterday. Clear? Absolutely clear? And what will you get on the biopsy? Biopsy में in light microscopy you will get FSGS. In electron microscopy you will get, learn it from a pathology teacher, but I will give you two keywords which are found. Number one is myelin figures and number two is zebra body. See, I am giving you all the possible MCQs. Beyond this, nothing can be asked in an MCQ exam. So I have given you all the, see, I could not have even taught you Fabry's. I could have easily escaped because strictly not my topic. But why am I teaching? Because I want you to learn everything. This could be in pediatrics, this could be I have taught in genetics, in pathology, in biochemistry, but still. Clear? So in electron microscopy you get myelin figures and zebra body, in zebra body, because of the parallel arrangement. Clear? Now what happens, these sphingolipids, they get accumulated in the kidney, in the lysosomes, and they create a pattern. They create a pattern, I will show you the figure, and they have two words, keywords, which are MCQ points. Number one, myelin figures. Number two, zebra body. Is it clear? Absolutely clear? Fabry's is very very important. Fabry's is very very important. और let me tell you, जब तक Fabry's में question आएगा, what in words will be given? Verticillata, angiokeratoma, Maltese cross, myelin figure, zebra body. If you can just remember 3, 4, 5, 6 words for Fabry's, nothing can stop you from answering Fabry's. It is that easy. Clear? Absolutely clear? Very good. Next. Next is a story. Actually, I was sitting in my nephro OPD and a mother came. Let me please understand this. There was a long queue. It was a government OPD in a nephrological department, and you know, a mother came with a son, and the mother said, "Sir, there is a problem, sir." I was like, "What, ma'am? Tell me." Mother said, "Sir, please listen. No, my child sometimes pees red." I was like, "Acha, what red?" "Sir, cola colored red, sir." Immediately understood the topic of glomerular versus non-glomerular. So it was glomerular hematuria. Very good. Acha, okay, very fine. No, sir, one more thing, sir. Tell. Sir, not only he, sir, my another daughter also has the same problem. Daughter also has the same problem, same age group. Acha. Sir, one more problem, sir. Many family members of my family have the same problem. So this same problem present in their father also, their father also, and probably their above generation also. I was like, okay. And that woman was crying. So some woman was telling, "Sir, so bad, sir, everybody pees red." I said, "Any other problem?" She said, "No, sir, no other problem. Baaki sab theek hai." I was like, okay. And you know, a woman who was standing next in the line of the OPD, she was listening to the story. And immediately she entered. I said, "Ma'am, please don't enter. Please you wait outside." She was like, "No, sir, I have to tell you something. Sir, this woman is crying ऐसे ही, sir. इसका तो दुख कुछ भी नहीं है, sir. Her pain is nothing." I said, "अच्छा, you have a more painful story." She was like, "Sir, you don't know, sir. I also have a son." I was like, "Okay, so what?" She said, "Sir, my son also pees red." I was like, "Okay, red meaning red?" No, sir, cola red." "Okay, you also having glomerular hematuria." All right. What else? "Sir, there is one more problem. His to father pees red. I mean the other first child. Sir, here to I pee red." Okay, so in the first case, multiple family members involved, brother, sister involved, father involved, successive generations involved. In the second case, the mother is saying, "I pee red and my child pee red, who is a male." Acha, you and he pee the same? No, sir. He pees red more than me, sir. I was like, okay. But why did you say that you have more problems than him? Why did you say that your pain is more than her pain? The first mother's pain? The second mother said, "Sir, she to only pees red. The first child only pees red. But my child not only pees red, sir, he has a lot of problems." I was like, "What problems, sir? What problems, ma'am?" She said, Sir, see his eyes, sir. His eyes are just coming out as if they are going to come out of the eye. I was like, okay, let me see. And really I could see as if her eye had formed an ice cream cone. I said, okay, only eyes problem extra, na? Only eyes problem extra, na? She said, no, sir. Then the child said, sir, one more problem. I was like, what? What happened? The child said, sir, I cannot even hear. Oh, you cannot even hear anything. You cannot hear anything. No, sir. I cannot hear Lata Mangeshkar, sir, but I can hear Mr. Amitabh Bachchan. I was like, what? You cannot hear Lata Mangeshkar, but you can hear Amitabh Bachchan. I was still thinking. Then his mother said, sir, one more thing, sir. I was like, now what? Sir, thoda sa retarded hai. Class 4 mein he failed twice. I was like, okay. So really your pain is too much compared to the first child. Yaar. So I was now thinking, what are they? They seem to be similar, yet they are dissimilar in so many aspects. And I was very, very confused. Next day I went to see the book. I read Harrison's, I read nephrology kit books. And then I finally got the diagnosis of both. Like almost you have already got the few. Has anybody understood what is the disease? Yes or no? I think somebody of you can. Yes, absolutely yes. The first patient is thin basement membrane disease, and the second patient is that of Alport's syndrome. So both appear. This is my last topic. Please bear with me. And if somebody is in too much of a hurry, somebody has too much important work, has to sign a 1 million crore deal, you can please do that. Clear? So these are my two patients. The first patient had an inheritance of autosomal dominant. The second patient, Alport's, has the most common inheritance to be X-linked, but which is more common than autosomal recessive, more common than autosomal dominant. So Alport's has 3 types of inheritance. If you are sitting in All India PG exam, you will mark X-linked inheritance to be the most common. But if you are sitting in AIMS or PGI Chandigarh, you will mark the Alport's inheritance to be X-linked, autosomal recessive and autosomal dominant. Next, this is the inheritance. Next, where is the defect? Where is the mutation? The mutation in thin basement membrane lies in alpha 3, alpha 4 chain of collagen 4. Whereas in Alport syndrome, the mutation lies in alpha 5 chain of collagen 4. But sir, we want to know everything. It can happen in alpha 3, alpha 4 also. So if you are appearing for All India, you will mark Alport's ka simple inheritance to be X-linked and simple site of mutation to be alpha 5 chain. But if you are appearing for AIMS or PGI Chandigarh, you have to know alpha 3 and alpha 4. So if you ask me, sir, which is what, sir, I will tell you the most common thing, the most common inheritance involves the most common collagen, and the less common inheritance involves the less common collagen. So if you ask me, autosomal dominant variety of Alport's involves which collagen? I will say alpha 3, alpha 4. But the most common Alport's, if nothing is mentioned, you will mark alpha 5 chain, inheritance is X-linked, and thin basement membrane disease is autosomal dominant, and the mutation is in the alpha 3, alpha 4 chain of collagen 4. I will take 5 more minutes. Please bear with me. Clear? Absolutely clear? Number 3, clinical features. Hematuria, hematuria is the most cardinal finding in both it is the most cardinal finding in both. So basically both patients, if you remember, had come to me with only one thing, that was red peeing. Red peeing. Is it clear? Next, proteinuria, hypertension, renal failure. I told you, the first mother told me, sir, मेरे life में सिर्फ एक ही problem है, that is red pee, no other problem, sir. So there was no proteinuria, no hypertension, no renal failure, but this had proteinuria, had hypertension, had renal failure, had all the three. Had all the three. Clear? And usually Alport syndrome enters end stage renal disease before 30 years age. Before 30 years age. Clear? Absolutely. Those who do not want to attend, please you can leave. Please you can leave. Those who do not want to attend. This is the presentation, and of course the prognosis is excellent, and of course the prognosis is bad here because they reach end stage renal disease before 30 years of age. I told you the first mother was sad, but was not as sad as the second mother, because second mother had complaints of proteinuria also, hypertension also, renal failure also, and she said, sir, I have a lot more problems because I have not only problems in the kidney, I have extra renal clinical features also. I have extra renal clinical features. Achha, wait. Before this, let me discuss the biopsy. Let me discuss the kidney biopsy. In kidney biopsy of, because we have only discussed kidney till now, of thin basement membrane disease, what will you get? The name is, everything is there in the name. You will get thin GBM, and that will be less than 250 nanometer. Probably I did not tell you the normal yesterday. The normal thickness of GBM is 300 to 400 nanometer. So you will get a diffusely thinned out GBM. You will get a diffusely thinned out GBM. Yes or no? And last but not the least, what biopsy finding you will get in Alport syndrome? You will get thin GBM with lamellations, and which have a classical appearance known as basket weaving. Which have a basket weave appearance. So you have a thin GBM, here you have a diffusely thin GBM. So the entire GBM is thinned out, and here the thin GBM has lamellations, and that lamellations give it a basket weave appearance. I hope I am absolutely clear. I hope I am absolutely clear. And I told you कि फर्स्ट मदर सेड, सर मेरे जीवन में और बहुत सारे दुख हैं. तो आई आस्क्ड हर क्या दुख है. शी सेड, सर फर्स्ट बच्चे के तो ओनली किडनी इज इन्वॉल्व, बट सर माई तो अदर ऑर्गन्स आर ऑल्सो इन्वॉल्व. अदर ऑर्गन्स आर ऑल्सो इन्वॉल्व. वॉट यू मीन बाय अदर ऑर्गन्स? सर, I do not have extra-renal manifestations, but Alport's का बच्चा has extra-renal manifestations. What sir? ऊपर से शुरू करें. Sir, he failed twice in class 4 because he is a patient of mental retardation. Number 2, sir, if you see his eyes look like as if they will bulge out like a cone because इनकी आंखों में एक अदाएं नहीं है, आंखों में लेंटिकोनस है, which is anterior lenticonus, which you have already studied in your ophtha class. Number 2, there is dot fleck maculopathy. There is dot fleck maculopathy, which is also an MCQ in the eyes, and there is corneal dystrophy. There is corneal dystrophy, and last but not the least, sir, in the ears, sir, I said he is hard of hearing. There is sensory neural hearing loss, which is bilateral. There is bilateral sensory neural hearing loss. And that SNHL was such that the child could not hear Lata Mangeshkar ji, but could hear Amitabh Bachchan ji. If he was a doctor, he would tell me, sir, I cannot hear the murmur of mitral regurgitation, but I can hear the murmur of mitral stenosis. Because sir, I know the murmur of mitral regurgitation sounds like whoosh, whoosh. It's a pan-systolic blowing murmur, and the murmur of mitral stenosis is the mid-diastolic rumbling murmur with a low pitch, droop, droop. This is a murmur. Clear? So basically, SNHL affects high frequency more affected. Is it clear? So this is the way both the mothers came to me, and both mothers had different patients, but they beautifully taught me two rare congenital diseases which are very, very important for MCQ exams. I hope I am clear. Okay? With this, I complete my today's class. Please, you are free to complain. Please complain that sir is teaching extra. Then from tomorrow I will stop teaching you only important things. Okay? Absolutely, you can do that. I will just show you a few photographs. I think you don't want to see the photographs. Leave it. So, I will end today's class. I will end today's class by saying that your future is created what you do today and what you do not, and not what you do tomorrow. Is it clear? Your future is determined what you do today and not tomorrow. So please do not leave things for tomorrow. You have to do it for today only. I thank you very much. These are my contact details. You can contact me anytime you want. I love you all. Be motivated. Have your dinner. I am very, very sorry for holding you back. I am very, very sorry for holding you back. Good night. Have a good day. Have a tight sleep. Okay?